All right, last but certainly not least, Dr. Agarwal will be talking to us about bone marrow transplantation for those with TBDs. Dr. Agarwal practices as a staff physician in Hematopoietic Cell Transplantation at the Dana-Farber Boston Children's Cancer and Blood Disorder Center. He also conducts impactful research in the TBD field that focuses on mechanisms and therapies for TBDs, and his lab is working on potential treatments for telomere diseases. He led a specialized multi-center bone marrow transplant clinical trial for patients with DC and telomere disease, and has much expertise and experience in this area. We are grateful to be hearing from him, and welcome Dr. Agarwal.
Thank you. Thanks so much, Kelly, for that great introduction. And it's so nice to be here with all of you. And sorry I missed the last 2 days. I just had a conflict for Memorial Day, but obviously I'd like to spend as much time as I can in this place with all of you, and it's been very, very important for me from the first time I joined the meeting in 2010 and provided direction for my career and constant inspiration. So thank you for that, and hopefully I'll show you some of what's come of that here. So I'll tell you about bone marrow transplantation. A lot of you are very familiar, intimately familiar with bone marrow transplantation, so you won't need the whole the background, but in case there are folks who want to contextualize or basically are actually still anticipating this, I'll give you the background first, but then I'll also spend about half of the time telling you about a disease-specific transplant trial that we did for bone marrow failure in patients with telomere diseases. That was multi-center, and basically the idea of it originated in here, also saying, you know, when folks were saying, how come you aren't studying this? How come you're not doing it prospectively, collaboratively, etc.? And this is the yield of that now 12 years later, 10 years later, anyhow. So for the purposes of this talk, we will simplify some of the terminology and just distill it down because there are a variety of things, so these terms are not completely accurate. So we'll say that bone marrow transplantation refers to any of these following: stem cell transplantation, hematopoietic stem cell transplantation, just consider them synonymous. Marrow failure will basically be regarded as a classic anemia, where one or more cell types are less than normal because of inadequate production. Allogeneic transplantation means it's coming from a different person, and we'll just say DC for everything, even though we consider it related to any genetic telomere biology disorder. You'll see from the trial we had to actually kind of tussle with that definition. So just to tell you the punchline first. The update now is that we completed the first multi-center prospective bone marrow transplant trial for bone marrow failure in DC. So basically that means we've done a trial with a certain regimen at certain places, basically saying we're going to do this and we're going to see what the outcome is. That's different than a retrospective study. It has nuances that are limitations in some ways, that we used bone marrow as the best graft that we could get, using well-matched related or unrelated donors. And I think the one thing this achieved was overcoming barriers of awareness and basically having something to offer people when they basically were faced with this, especially people and places that have only ever seen it one time. It was leveraging timely diagnosis, which has been increasing over the past 10 years, and it actually is breaking down some of the barriers between collaboration internationally. But what we still need to know, also getting to the punchline first, is what to do for other types of donors when you don't have a well-matched related or unrelated donor, especially these days half-matched or haplo donors, other types of cell sources like cord blood, and for other disease manifestations that actually are prevalent more in the adult population that is being identified with TBDs, including myelodysplastic syndrome and leukemia. So this is for marrow failure, not the malignancies. So just to kind of contextualize the problem, so bone marrow failure is a frequent occurrence defined by significant defects in one or more lineages in patients who present classically with dyskeratosis congenita. So here we are talking about the classic manifestations that more than 90% of those patients roughly will develop some significant cytopenia by the time they're in their third or fourth decade of life. And the way we can think about this more intuitively for the marrow and blood system as opposed to the other parts of the body is that you have a blood stem cell and it's required to produce, this is what the bone marrow looks like, a lot of different types of blood cells, like these are the things that give rise to platelets, these big fat cells over here. But this kind of just mixture of a lot of cells is what a normal bone marrow looks like. And what happens over the course of life is that this cell has a certain ability to replicate and and while it's replicating, the telomere shorten, and even though it would actually be required to give rise to the blood system throughout our entire lives, eventually it exhausts and we end up with an empty-looking marrow. And so that's what we see sometimes when we look in the marrow of patients. And so the goal of the transplant is to replace primarily that failing blood system, and also would be, if the patient is presenting with myelodysplastic syndrome or leukemia, to cure that, or at least eliminate the risk. So you should, in theory, be able to get rid of the risk of developing myelodysplastic syndrome from replacing the blood system. And some patients have a poorly functioning immune system along with it, and the idea is to then also replace the immune system for those patients. So the goal is then also, in the process of doing this, minimize damage to the rest of the body and get back to regular life with respect to the blood problem at least. The limitation here, though, with fixing the blood system is that only fixes the blood system. So it's not expected to fix or prevent the other problems in DC. So the main goal is not to make things worse. It's about to basically just to get rid of the blood problem there too. So when thinking about the timing, it's determined by the type and severity of blood problem. It's very different for different people. Some people present for the first time ever with DC with a completely failing blood system, and they're needing some sort of intervention at that exact moment. And other people get detected as having a telomere biology disorder by virtue of having a slightly abnormal CBC, or even just by genetics in the family, and you're watching them as we talked about before, and trying to figure out what's the right timing for actually doing something or intervening. And this is a very common scenario across the entire spectrum of ages and presentations as well. In some ways, someone coming in transfusion dependent is an easier decision. You basically just have to act, right? So transfusion dependence is one indicator, or unfortunately, while we're basically observing them, hopefully not, but if they present primarily the day they present with the fact that they actually have already myelodysplastic syndrome or leukemia. And the other determination for what you're going to do and how you're going to do it is the availability of a suitable donor and what the graft source will be, whether or not there's a window for trying other things, observation, transfusion support, androgens. Some folks in the community have basically been on androgens for years before they decided to go to bone marrow transplant. And for some people, it didn't work at all, but that was temporizing for a while. Consideration of age and other medical problems, and we'll talk a lot about that. And then the advice from the physician, and then also the patient choice. And all of those things are not set in stone. It really is even the physician advice. You'll hear different things across the globe about whether or not patients get transplanted or not. And that's based on what they have as a perception of the overall risk for patients with this too. So we have to count, sometimes those aren't absolutes. You have to push back on them sometimes, or basically question them sometimes to see what the right thing to do would be. So the overall timeline for transplant, it takes, imagine that someone's coming in, you've either decided it's now time to look for this, or they're coming in and basically needing a transplant right away. It takes weeks to actually check the patient, check their HLA type, find an appropriate donor, if you can, in the family or in the registry, and confirm their typing. And then in the few weeks that precede, checking many aspects of immune function, infectious risk, etc., and preparing for the patient's admission, and also the donor for the donation. The preparation of the body to receive the cells, which is basically composed of agents that actually are supposed to get rid of the blood system, and we'll talk about those in detail, and suppress the immune system, is called conditioning, and that'll be a different type of regimen over some days. And then transplant is day 0, so it's basically where the cells are infused. In the immediate post-transplant period, the patient's typically inpatient for about 4 to 5 weeks, sometimes less, sometimes more, depending on how the engraftment has happened and how the rest of their body is actually handling it. And then the patient requires close surveillance for the subsequent year, roughly, while they're basically coming off all of the medications. Their new immune system is starting to take hold. They're able to get immunizations and actually have some sort of protective immunity against all the other things in the environment. And prior to COVID, that was always painting a picture of some sort of isolation, and now it's actually much easier to just tell people it's kind of like COVID was. When people were in lockdown, you're basically trying to avoid social interactions that you don't necessarily need, and also be isolated from school or work. So in terms of graft sources, there's 3 main types we talk about. Bone marrow, I already alluded to, so this is basically the cells that would give rise to the entire blood system, basically being taken directly out of the donor's bone marrow, so with a surgical procedure that basically uses aspiration of the bone marrow, sometimes up to a liter, depending on the size of the recipient, and the healthy donor can tolerate that. The other way is to basically try to get the stem cells out of the bone marrow by giving things like you already heard about GCSF, and that actually raises the white blood count of the peripheral blood, and the stem cells can be actually collected from the peripheral blood of the donor. And then finally, cord blood, which is basically stored in banks from unrelated donors with a certain type of matching, and basically can be used as a graft source. HLA typing, just briefly to demystify this. So basically, you have different genes in your body that are responsible for determining self versus non-self. So it's helping you to fight infections, and these are the major determinants of whether or not you can accept a bone marrow graft. So if you match them up correctly, you should be able to accept it without actually rejecting the graft, and the graft shouldn't reject you. You shouldn't actually have a problem as much with basically the graft attacking you. That's the goal, that's the idea. Every nuance beyond these genes can actually happen where you can have graft rejection or graft versus host disease. But this is really what the primary matching is. And just getting back to organ transplant, you usually don't have the luxury of trying to match on these. If you could, you should have a better outcome, but you don't. The matching in organ transplant has to do with blood type and has to do with infectious status as well. But there isn't that much attempt or feasibility of actually matching on these types of alleles. So it's quite a fundamentally different thing. In fact, you can actually transplant across different blood types from the bone marrow standpoint, which is not the case for some organ transplants. So the level of match would be that if you match both copies of each of these, a good match these days would be called 10 out of 10, because you literally are matching across those. A parent would be expected to be half matched, unless by chance they were matched more, so 5 out of 10, that's haplo. 5 out of 10 as a match is not, except for a relative, is not really considered an acceptable match. You really need to be on the north side of that too. 9 out of 10, 8 out of 10 are probably what are acceptable when you're looking into the unrelated donor pool. So you basically will determine this either for siblings, who would be the highest likelihood of being a match, or somewhere out there in the registry, someone who's unrelated to you and happens to be matching you at all of these points. In terms of graft sources, we prefer match-related, so a sibling who's fully matched and then matched unrelated are actually turning out to be good outcomes. There's some debate about this in different fields. I'll just tell you my biases, and we can argue about later. Mismatch unrelated with single or two alleles in the donor pool versus haplo, which I would basically go out to say that we don't really know how to do a haplo transplant properly for patients with sclerosis congenital. Graft sources, bone marrow has the best chance of actually replacing the system that's failing and not cause graft versus host disease. Peripheral blood stem cells would be the next preferable source, and then cord blood is not an inferior source by any stretch of the imagination. It has some limitations, and we don't have a protocol really for it. So in our protocol, we'll basically go in this order or as per our protocol. And then the conditioning. This is what I was telling you about, where you basically have to get rid of the blood and immune system of the patient who's receiving it. So in the broadest sense, you give chemotherapy and radiation to get rid of the blood-forming elements, and then you give things that actually suppress the immune system, and those are antibodies and another agent called fludarabine. And it's some combination of these that you use to actually achieve a successful graft, and it's this that we manipulated in our trial for patients with DC. So the transplant itself is just stem cells. It's infused in the vein for the recipient, as opposed to getting something out of the bone or putting into the bone, like a blood transfusion. And we already talked about the post-transplant stay for weeks, where you need to see signs of engraftment, ideally, and basically be able to administer the GVHD preventing medications, monitoring for toxicity and infections, and then that there will be an outpatient program of care for months that follow with frequent visits back to the clinic. Graft versus host disease is the reaction when the cells coming in think of you as foreign, and there's many, many efforts to try to mitigate this, including some medications like cyclosporin and MMF, and also matching the HLA type. It itself can be life-threatening, but it can be controlled with other medications too, and there's different phases of it that are called acute and chronic. So this is something that you'll hear talked about a lot when people are talking about what are the risk factors and what you're trying to prevent. Primarily, I would say for DC patients is that this attacks a lot of the same parts of the body that are already susceptible in DC patients. So it's a high priority to try and mitigate graft versus host disease. And infections, while you've actually gotten rid of the blood system and the immune system, this is one of the main things that you're trying to prevent and one of the major causes of complications. You can get bacterial infections due to low neutrophils, or fungal infections as well. Viral infections are a common problem, ones not only that come from outside, but also ones that come from back out from within the body. This is something that's monitored very carefully. Viruses like CMV, EBV, HHV6, these are inside you, and they're being suppressed by your immune system, but they can reactivate when the immune system is suppressed. So the management is close monitoring, very low threshold for evaluation and hospitalization in periods after transplant, and restricting interactions that may make somebody susceptible to infections. And then another very important concept is the monitoring and the tracking and the mitigation of late effects. So late effects are defined as a condition that occurs after the acute phase of an earlier causal condition that's run its course. So in this case, it would be talking about the transplant itself, but it can be caused by the transplant or the treatment of the transplant, or also both, and also in this case, very much so, the susceptibility to that from having this keratosis congenita, having some organ that's partially affected. And the various components of this are, in terms of thinking about late effects and why somebody needs surveillance over the course of years that follow, are not only the primary disease and knowledge of the primary disease, but then also taking into account what did the patient get before the transplant treatment, what was the regimen that they got and how did they respond to it, and what were the complications. And here just given GVHD, but it could be that any type of additional complications ends up dictating what needs to be a very tailored approach to surveillance of late effects. And what we often do is that in the category of the pediatric hematologist or bone marrow transplant physician, we're kind of looking at both of those elements at the same time, but that's different in different parts of the world and different types of medicine, including adult medicine too, where you need somebody's eyes to be a little bit on the DC part of things as opposed to the bone marrow part. But you can see here, it makes sense to be looking at them simultaneously and to be contending with them, because many of the different parts of the body that are affected by DC are also the places that late effects of transplant and graft versus host disease affect. So this is a table that's, I think, slightly modified, but in the guidelines, and it's important because it says when you come for your post-transplant care, it really should be that you're actually having all of these things covered. So when you stop doing your post-transplant care, it's also these things that aren't necessarily being covered by any individual in a holistic fashion, and someone needs to be looking at both of those elements of you. And it's not uncommon that there's someone who's wondering, is this a manifestation of the transplant? Is it GVHD, et cetera? Or is it something that's actually because of dyskeratosis congenita? And it's a common problem and an important one to engage. So in terms of trying to minimize, it's a real goal to not only try to get the graft in and get it functioning, but to minimize the late effects of BMT and DC. And this is trying to balance the intensity of medical surveillance and preventive measures and optimizing quality of life after getting over this phase of therapy. But it does require comprehensive regular follow-up and evaluation, ideally at an expert center looking at both of the effects, as I mentioned. Surveillance and early detection of complications, not only for the function of the new hematopoietic and immune system, the blood and immune system, but also for the other things that may be happening. And I say it that way because it's very common to have changes in the blood counts after transplant for DC, and to wonder whether or not that's a reflection of something going on with the graft itself, or whether its function, or if it's a manifestation of something else that's actually going on in the body because of DC. And those, if you have the transplanter looking at it alone, they will view it with one set of eyes. And if you have a person who knows DC also, or they'll be looking at it differently too. And a very common example of this is the platelet count trajectory after a bone marrow transplant, which will sometimes be normal and then start to descend. And it's not descending because of the graft failing, which is commonly, or it could be, but you need to evaluate that carefully because it very well could be just a reflection of liver disease, for instance, too. And so in order to optimize, obviously all of that, both the surveillance part, but also to try to optimize heart, lung, and other risks post-transplant as well, so you don't have another cumulative effect. So just in the last few minutes, I'll tell you about the problem that we're trying to address and solve in transplant. These are generally very hard problems to solve in a short period of time. The studies that you want to do accrue very slowly. And the data that you need is obviously, for its importance, long-term types of data, but this is what we have over the past 10 years or so. But this is one study from Sharon's group by Suneet Agarwal, which was a retrospective of the CIBMTR registry showing that this is what the problem has been. And there's several other studies that I've shown and other people have shown before that basically show that in the beginning, what was clear is that there's a very high rate of mortality after transplant. A lot high rate of death, 30% within 4 months. And so that was at least one component that seemed to be connected to the lack of tolerance of the conditioning of the transplant. And then there's also a relatively poor survival over time. So this is, of course, in patients with classic DC because they were reported over the course of many years, 1981 to 2009, as having dyskeratosis congenita. So they must have had that phenotype. So you have to take that into account too. But either way, this is the problem that people were having in terms of recommending bone marrow transplantation. And certainly in this field, and then also from others, it was recognized that it must be the conditioning that's causing some of the problems. And in Fanconi anemia, there was a lot of advancement that had been done in trying to reduce this upfront toxicity. So these are the conventional conditioning agents that when you're trying to cure leukemia, you'll give them at very, very high doses. So they have leukemia, they're immune suppressive, and they make space. We're talking about the need to make space in terms of being able to get the graft in. And then the blood stem cells can basically have an anti-leukemia effect too and replace the blood system. But the problem with these agents is they cause collateral tissue damage and short and long-term complications. And they're individual to individual variation, and they are dose-related too. So it's not a universal sort of thing, but the idea was that in aggregate, this was actually causing a problem. So advances both in Fanconi anemia and then also with a prospective trial that Jacob Tolar had started was basically trying to say, why don't we actually reduce this significantly and try to drop it down to a certain dose and see if you can actually get a graft in. So we just took this to the next level by basically saying, what if we actually don't need an anti-leukemic effect? What if we need to make space? And what if we actually get rid of these agents altogether, since the patient already has an empty marrow, and we can get rid of the chemotherapy and radiation and see whether or not we can achieve some engraftment with immune suppression alone. So this is in 2012. And so what we did was we basically used agents that were already used in transplant, but they're primarily directed at the immune system. So one of them is an anti-CD52 antibody, which basically just depletes lymphocytes very rapidly over the course of about 48 hours. And fludarabine, which is a chemotherapeutic, but it's not the type that goes throughout the entire body and damages the lung and the livers, etc. It's just basically primarily affecting the immune system and to some degree the blood system as well. And in this regimen, we said we will use a bone marrow graft and we'll use GVHD prophylaxis with conventional agents. Also, we'll avoid steroids and methotrexate and other things like that. Just look at the time here. So the eligibility here was marrow failure, so that's important. This is for marrow failure, and like I said, not for myelodysplastic syndrome, because when you reduce intensity, there's a concern that the patient will have too high a chance of relapse. And we defined telomere disease broadly. So essentially, it ended up being a group of patients who had very short telomere length by flowfish, and they needed to have a well-matched related or unrelated donor. That was 7 out of 8, which is slightly different than what I showed you, but a degree of match that didn't have to be perfect. And we didn't exclude people deliberately for having concurrent lung or liver disease, because we thought if we reduce the intensity, we may be able to provide a path for them if they were stuck between having this simultaneous liver and lung issue. So our primary goals were basically to see that the blood counts are covered and that they were primarily from the donor, and we were looking for survival, both short-term and long-term, and other effects as well. So we started this trial, as I mentioned, in 2012 as a single center, and basically started treating patients there for a variety of reasons, including logistical and how much uptake would there be, would it be feasible to do this. And then very nicely, it feels so long ago now, but what we basically did through conversations at this very meeting and with Team Telomere Dyskeratosis Congenita Outreach, and basically essentially enabled by one of the earliest $1 million bike ride grants, we basically said, let's expand it and basically open it up at more centers. That was before, we did that before we even finished what we predicted to be our trial. And we basically we accrued the number of patients we expected to by October 2018. But then we went ahead and just kept going because there were more and more centers that basically were interested over time. And we finished a trial of 40 patients in January 2023. So the data I'll show you, because it takes some time to aggregate the data of the most recently treated patients, is not relevant because they're so soon after transplant, but this is 35 patients with more than 1 year of follow-up. So this is the characteristics of the patients, and just in a nutshell, to be brief about it, you'll see that's what I mentioned. They may or may not have had dyskeratosis congenita. They may not have had any other signs of the classic triad. But what they did have was marrow failure, and they had very short telomere length. And so that was the way, essentially, the common unifying theme for all of the patients. They were a huge age range from 20 months old, and most recently a 51-year-old patient treated on the trial. Several were adults. There were patients with the syndrome versus not, with genes identified versus not. And I think probably one of the most important things was that there were a huge number of unrelated donors. Because I would say that there was also a kind of theme running out there, is that the transplants are so bad in these patients that you don't transplant them with unrelated donors. So this experience allows one to look at what happened in unrelated donors too. And I would say that we took at least 4 patients in who we would have not treated at our center because they had a significant comorbidity, a liver disease problem, a lung disease problem. They would have been excluded if we didn't actually have a protocol open. But once you have a protocol open, you follow the eligibility criteria and say, we're not just going to go by our gut feeling, we're going to say whether you're in or out. And I think that's another useful outcome of this. So this is the primary engraftment. So the first question is, did you engraft and when? So this is, if you have an uptick here, that means you engrafted and you engrafted on that day. So there was a range of when people would engraft defined by their neutrophil count being recovered, and 34 of 35 engrafted within the time frame described, and one engrafted later. And we can go into why that happened. It's a story about having a large spleen, but we can talk about that another time. But ultimately, all of them engrafted. And what about the durability of the graft? So if it goes in, that's great, but you want it to stick around. And one of the biggest risks in this protocol is that if you reduce the intensity of the conditioning, that the patient might still have the capacity to reject it. And that happens even with higher intensity regimens too. Historically, there was a 17% graft failure rate in patients with DC, even with higher intensity regimens. So in these patients, we found donor chimerism to be achieved, and we had sustained mild engraftment though in 28 of the 35 patients, so 80%. So 20% of the patients did reject their graft, and that's these ones. And basically you can see that what happens to be observed is if they're going to do it, they do it within 2 to 3 months. So the counts might come in just fine, and then all of a sudden they're gone. And that's a very concerning period of time. So the question then becomes, if you did all of this to all of the people in order to get some in, what happened to the people who had graft rejection? Were you able to salvage them? And at least on the protocol, we were able to salvage 5 of the patients, meaning you go up for a second transplant and see if that can be successfully achieved. And one of the patients, their blood counts came up sufficiently that their primary team has not transplanted them again yet, and they're observing them with imperfect blood counts too. So that's called the salvage rate of the transplant too. So that's not a number to take lightly, that 20% of patients will reject, but that means that 80% of the patients didn't get exposed to any of those agents and were able to be engrafted. And so then this is the survival. So this is the 5-year survival curve. So remember we were talking about this part of the curve, which is actually a high transplant-related mortality that's early on. So that has been improved. So we basically have a 5-year post-BMT survival of 89% compared to the historical. There were the 2 deaths that happened within 100 days were related to the transplant. That wasn't because of DC, that was because someone had actually undergone the transplant and they got an infection. And the infection they probably wouldn't have gotten if it wasn't for the fact that their immune system was ablated. So that's the difference between, this is an aggregate probability of infectious deaths and also deaths from toxicity of organs, and that's what's actually what's remaining. And so what's the other question is that what happens longer term in these patients? And this is the part that's actually more sobering. Now the number of people being evaluated who are this far out is very low, so that's why there's huge drops in the way these curves are drawn. But what's happening is that patients still, if you follow them farther and farther out, do develop complications of liver and lung disease. So if there's something happening later, it's most likely the result of DC and us needing to keep an eye on it. And so that's the unmet need still. We can basically do this in transplant to prevent this upfront, find this window of time where people can actually have their blood system fixed. But now we basically need a fix for this other part of it too, and that's the sobering reality. And in these cases, especially since these were pediatric, you will recognize that some of these were deaths due to hepatopulmonary syndrome, which actually at the time that we started the protocol, we probably didn't even recognize it in its full form at that time. So unfortunately, transplant doesn't cure the non-hematopoietic manifestations of these, but at least it's an option in the beginning while we try to find other curative therapies. So in summary, this study showed that this regimen is an effective strategy for BMF in patients with DC or short telomere length. We have favorable engraftment and salvage rates. I didn't show you this, but very low rates of GVHD. We can talk about that more, and survival rates. And it may allow transplant for very high-risk patients to be done in patients who have comorbidities of the lung and liver. And I already alluded to it before that the lung ended up being less of a problem in at least the patients we treated than liver disease, which was very hard to manage. So what's interesting about this is that this is where I think that doing studies even in a rare disease population paves the way for the field. So this is the first set of patients in the entire field of allogeneic transplantation who's ever gotten myeloid engraftment without actually getting any radiation or alkylating agents. So it ends up showing feasibility of doing that in consideration of that for other diseases as well. But what we're mainly concerned about right now are the long-term outcomes of patients and also planning now the next studies. If this is now closed and we have this consortium, can we think about what we do for alternative graft sources? And what's on a lot of people's mind is this the haplo transplant, basically being able to do it with a half match, and how do you do that? And also, an unmet need and very important is, as more adults are being diagnosed, how do you do this for MDS and AML and immune deficiency as well? All right, so I'm just going to show an acknowledgement slide that basically just highlights essentially patients and families and Team Telomere who basically enabled all of this, and the grant was the $1 million bike ride grant from Team Josh and the DCO writers in the beginning, and now carried on. But that really kind of cracked this open and allowed us to enroll many centers to actually execute this, and this is an incredible group of people who were doing this very much out of their desire to just try to make things better. Even if they were seeing literally one patient, they would take the time to open the study and actually do this. So this is a great group of folks we hope to do more studies with too, and again, entirely enabled by this group here, and we thank you for that, and hope that we can actually make more progress in some of the other blood manifestations too. Thanks.